So really one of the big questions is if we can accurately distinguish between luminal A's and luminal B's, we can determine which patients need chemotherapy. But as I've told you, the Ki-67 helps, but it's not perfect. And so this is where those molecular tests that we're going to talk about later on in this talk really start to come into play to help us determine which ones are more like those luminal A and which are more luminal B. But before we come back to that, let's finish looking at our categories. So our HER2-enriched category, there is high expression of ERBB2, which is and other genes that are on the 17q amplicon on these guys. They have lower expression of our luminal genes, so lower expression of estrogen receptor, lower expression of progesterone receptor, and they're typically ER negative, so about 70% of the cancers that fall into the HER2-enriched category by expression profiling are going to be ER negative. The rest will be ER positive. What's interesting about this is only about 60% of HER2 positive cancers by IHC or by FISH are clinically going to fall into this group. Does that alter treatment? No. As you guys know, any cancer that's HER2 positive is going to get treated with anti-HER2 therapy. However, it's interesting that there's this smaller subset that falls into this HER2-enriched group. The rest of those, and I'll show you the split, but many of the remainder are actually going to fall into that luminal B, but they can sprinkle elsewhere as well. This is a group that we talked about before is very likely to achieve a complete pathologic response with neoadjuvant chemotherapy. And it's this HER2-enriched group that tends to do really, really well. Actually better if you have a HER2-positive tumor and you fall into HER2-enriched molecularly, you do better with neoadjuvant than even if you're HER2 positive and don't fall into the HER2-enriched group, which is kind of interesting, but obviously not something that we know on every case that we're looking at. Also, these patients may benefit from dual HER2 blockade, although this is not really how our oncologists are determining when to do that. So what's interesting about this, and we've talked about this, is HER2 positive disease in and of itself is clinically and biologically heterogeneous, even though we tend to see, when we see HER2 positivity, we sort of say, oh, it's HER2 positive cancer and are finished with it. All of these patients are going to get anti-HER2 therapy, but they behave differently, and it's just kind of interesting. It's not so much from a practical standpoint. But you can see 55 to 60% of these patients fall into the HER2-enriched. A lot of the rest are going to be luminal, mostly B, and that's why you see that HER2 positivity sit in the luminal B category. A few of them will be basal, and then we'll talk more about this. This is probably all an artifact, which we will talk about. So a key takeaway here, for your understanding, is just because cancer is HER2 positive, it does not mean it's HER2 enriched. However, that doesn't change therapy.